the way that the mRNA vaccines work is basically you have a sequence of the viral genome that codes for the protein that actually binds to your cells. So in and of itself, that mRNA sequence is not enough to do anything. It's not the whole virus. And mRNA by itself, without the viral proteins around it protecting it, is unstable. It's not going to, it can't revert into a new virus. It can't itself really cause any viral effects. What happens is your body takes that mRNA sequence in, it reproduces it, it creates this one protein that is made by the virus, and then your body sees that one protein and then creates immune response to that. So you're basically taking all the parts of the virus out except for the one piece that binds to your cells and introducing its precursor into your body for your body to itself make it and then mount an immune response against it. Yeah. So it's really a pretty genius way of exposing your body to the thing that it most needs to create an antibody against in the safest way possible.
Chris, Dr. Moriarty, I'm thrilled to have you back on. You've been on the podcast so many times in the past year, and I swear to God, when COVID is done, we will have a conversation just about jiu-jitsu, not at all about COVID. But unfortunately, you've been cursed and we've been blessed by the fact that you're a very, very high-level jiu-jitsu black belt and a medical doctor and have done a ton of research on COVID. And it's a little bit terrifying to think that people are coming to me and to some extent to you for advice on COVID when there's various international government organizations and non-government organizations and people who do their epidemiology for their whole lives who aren't being listened to. But I suppose we provide a little bit of context for how to act in the pandemic if you love jiu-jitsu and if you enjoy that super close contact, which we both do. So we will one day talk about jiu-jitsu and only jiu-jitsu. But for now, how are you doing? And let's plot out what we're going to talk about today.
I'm doing all right. You know, if I move in, we tried to do this with me working out of like the kind of common area / office at my apartment complex, but the connection sucks, so I had to go back home. But I have a 13-week-old puppy who, it's a long-haired Chihuahua. Ron is his name. He's going to just cry the whole time if I'm not like playing with him or holding him or something. So I might be moving around and stuff during the thing, but I'm all right. You know?
Well, it makes it a little bit less threatening. So I like the Chihuahua prop. It's funny. Bas Rutten was once, somebody was making fun of him and he's got some little dog that should fit in some blonde's purse. And people are like, you should get a tough dog. He's like, screw that. I'm tough enough. I can have whatever kind of dog I want.
Yeah.
So I thought we'd start by talking about sort of the COVID long hauler syndrome and long COVID and post-COVID syndrome, and then pivot very abruptly to the whole discussion of vaccines, variants, and what implications getting vaccinated and the presence of vaccines has for training jiu-jitsu. Does that sound like a reasonable couple of things to discuss at this point?
Yep, perfect.
Okay. So when it comes to people experiencing COVID, I mean, some small but significant percentage of people die if they get the illness, and we can argue about the case fatality rate, the infection fatality rate, and we've done so on previous episodes. I think you've been on the podcast 3 times, and if people want to go back to episode 268, 273, and 283, they can see how your and the general medical community's understanding of this disease progressed through time. But I think it's become apparent that some people are very strongly affected for a long time. Just to make this personal, in my fire department, there's 8 guys who've had it, all fit. Like we're talking guys who are doing CrossFit 5 times a week or run a marathon on a 1 day's notice. Ages 25 to 55. 4, it was super minor, like a flu, the sniffles, fever, and then gone. And 3, there was quite a long recovery period. We're talking 6 weeks-ish. Some of them aren't 100% better. And 1 guy the youngest guy, 25 years old, is still very heavily under the weather. Basically goes up a flight of stairs and has to stop. And he was, again, very much in shape to start with. So I think we're getting more and more personal examples of people who are, long haulers, or the disease is coming back to haunt them after the fact. Are you seeing this? And what's your take as a medical doctor on this long hauler syndrome?
Yeah. So, I have some anecdotal experience, just in my clinic, seeing a couple of things like this. And then, like I was telling you before, I work for Indiana University, and our acute inpatient rehab center, which is a kind of hospital where you go after you've been in a regular hospital, but you're stable medically, but you wouldn't be safe to go back home, and you have significant functional deficits or pain issues that would prevent you from being able to go home safely, or even to what people are more familiar with in terms of rehab facilities, we call a subacute rehab facility, where, for instance, your grandmother might go after a knee replacement. So that's part of what physiatrists do. I'm more on the outpatient side, but I do have to cover that unit sometimes, but that's the inpatient physiatry. And we have an annual staff meeting, and that just happened on Tuesday of last week. And the cool thing this year was that the keynote speaker for it was a group of people from Mount Sinai in New York who had
ground zero, in other words.
Yeah, ground zero for the initial outbreak, who had come together and basically created a post-acute COVID syndrome clinic from scratch. And they did it based upon just the needs of the patients they were seeing, that you'd have these patients that were being discharged from the hospital after some of them weren't necessarily vented, a lot of them were. And they would, complete regular, outpatient rehab and go home, but they weren't really ever able to integrate themselves back into their own lives, whether it was just excessive amounts of somnolence or sleepiness, fatigue, cardiorespiratory fatigue, not being able to walk a block without being out of breath. Really interesting pain syndromes like diffuse myalgias, or so muscle pains or joint pains. And then really interesting neurocognitive, neuropsychological problems where they are just short-term memory would just become really poor. Their attention was really poor. They have a hard time functioning in their jobs. And the interesting thing to me was when they were initially describing this, it sounded a lot to me like what we sometimes see in people with untreated or unrecognized traumatic brain injuries. So not like a severe traumatic brain injury where the skull was cut open or something like that, but somebody that had a really significant, let's say, motor vehicle accident, and then they were never quite the same after that. You can never quite put your finger on it, but sometimes I'd see people like that, they come in to see me for neck pain or back pain. And just talking to them, you get this impression that there's something missing. And then when you start to do more of a kind of probing at their cognition, you start to see, wow, like this person used to have this job, and now, yeah, they're still working, but you know what I'm saying? And it's like, it kind of reminded me of that. And so it was like a 2-hour presentation. Basically, they were prompted to set this up because these people were leaving these rehab facilities and having these extensive workups, repeated imaging and pulmonary function tests and, stress tests and things. And they weren't able to find anything, that was just like, this is your problem. And so a lot of these patients were being told, that it's all in your head, or, you're just, worried or whatever. But these people were really having problems. So they set up this clinic, and they created a really cool integrated clinic where they have, physiatry, neuropsychology, physical therapy, occupational therapy. And they're even working, they started working with an immunologist. I can't remember where she's from. And she started sending them some serologic assays for, inflammatory markers that are really used in research. And they're starting to work with those. So the really interesting thing about the research was that initially they were seeing all these things that reminded them of other conditions like post-TBI, post-respiratory failure. And then when they would start to try to implement these rehab strategies, they were just finding that in many cases, people just could not tolerate even the slow graduations in progression that they were used to using.
So that would be like gradually increasing the speed of walking on a treadmill or something.
Right, okay. Exactly. Or, let's say that somebody's got you think they have an old traumatic brain injury and they have some, problems with executive functioning, like planning, organizing their lives, which is important for everybody, but especially if you were in an executive position or somebody that required a ton of organization in your life. And these people, and this is just from what they were telling us, that they were having difficulty even putting people through the batteries because they'd become so exhausted, mentally exhausted and even physically exhausted during the examination. So even because these neuropsychological evaluations can last an hour or two, right? They're really in depth. They were having problems just completing those. And so they had to basically start from scratch and rebuild a whole new model of incremental rehab and be able to stretch out how long these people were in the program for, because, insurance normally only covers a certain amount of time. And so they're just starting now to really get some research out because, like we were talking about before, you can identify a problem that you think somebody has, but then you have to more generalize it to a group. And then once you find the same, abnormalities, then you can say, okay, we're seeing this pattern, and then you can kind of start to publish it. And that's kind of where they are at this point. But I think that these kind of clinics, these kind of integrated clinics are going to start to pop up. In my personal experience, I can think of, the two that I can think of right at the top of my head. One was it was a lady that was referred to me for kind of pubic region pain, like the front of her pelvis. And it ended up being that, thankfully she just had really bad hip arthritis, and I was able to inject her and get her some PT, and her walking improved significantly. She became much more confident, but I just got a note from her therapist the other day, and he was saying that, she's still doing so much better. Her pain's so improved. Her gait is essentially normal, but she says that when she leaves the sessions, and keep in mind that she was hospitalized for COVID in April.
Wow.
And she finished, so
8 months
she was
ago.
vented. Yeah, she was vented, and then she was in the hospital for a month, and then she was in acute inpatient rehab for a month, and then subacute rehab for like another 2 weeks or something. And then she went home, and then I saw her like a month later. And he says that, the only issue is, when she finishes, she says she goes home and she sleeps hard. She's just exhausted, wiped out, and she's really just walking. You know what I mean? So, but fortunately, she's continuing to improve. I haven't seen her since all of that. You know what I mean? So I'm looking forward to seeing her again. But the one thing I remember when I saw her the last time was that she had basically presented to me like someone with post-traumatic stress disorder. She started crying when we were talking about, she was just talking about being afraid to go outside, even with a mask, even in social distance situations. She couldn't sleep at night because she was afraid if she went to sleep that she wasn't going to wake up, that she wasn't going to be able to breathe. She would just start crying randomly throughout the day. She wasn't communicating with her family. And so fortunately, we were able to get her in with a counselor and psychiatrist, and they're starting to work with her on those issues. And that's just one person in one situation. So you got that extreme, almost like non-physiologic fatigue, and really essentially post-traumatic stress disorder from being on the vent and almost dying. And then I had another guy present to me with, he had COVID, and about a month afterwards, he started having bilateral wrist pain, bilateral knee pain, and left ankle pain. No history of any injuries, no previous, trauma in athletics, never rolled his ankle, nothing that you would typically look at. And he was complaining of ankle swelling. When I saw him, his ankle wasn't swollen, but it was very tender, but his ligamentous exam was normal. It's just very strange. I mean, there was just absolutely nothing besides this COVID situation, So
My only reference point there is the time that I had C. diff, and that's a very strong. It's an infection, but it gets a very strong inflammatory reaction throughout the body, and
Yeah.
everything hurts. It feels like you have arthritis in every joint and moving every. Is this runaway inflammation, or is this something?
Yeah, you can. So you can get like there are a lot of there are a lot of viruses or and bacteria, especially the GI stuff, that'll cause like an aseptic polyarthritis, where if you try to tap the joints and remove fluid, you're not going to find anything.
Mm-hmm.
But people have, you'll find a bunch of inflammatory cells, and the joint will be swollen, and it's kind of just, it's maybe we call molecular mimicry, where your body's kind of attacking a tissue that maybe has a couple protein sequences that are similar to the initial infection or something like that. But I've heard a lot about that, but I hadn't seen it before. And it's kind of weird, because you'll hear people say that, but when it presents to your clinic, you're like, because you're trying to impart logic on the situation, and it's just, that's all, I have a follow-up with him pretty soon, so I don't know how he's done based upon what we did, but, I had, and then I had another lady that she was vented and trached, and she ended up seeing me for low back pain, but I don't think necessarily that was related. But I've been hearing a lot about this from other physicians, and this is somewhat unrelated, but the most shocking thing that I've heard recently from friends that I have that are intensivists are the people that are almost refusing to be intubated. This is a kind of a different topic, but refusing to be intubated because they don't believe that COVID is real. I mean, we still have that part going on, which is a different conversation, but I think it made me think
honestly, if we start going down the conspiracy,
I don't want to do that.
Like that is I've diverted about half this podcast to talking about conspiracy theories, and just recently there was a fucking protest / obstruction at
Dodger Stadium.
Yeah, like it's one thing if you want to die and you don't care about other people, but don't actually stop people from doing the right thing.
Yeah.
But
anyway,
okay, so just for people who are listening who either know somebody who's had COVID and is having a hard time getting over it or has had it themselves, it sounds like we're still in early days of figuring out how to treat post-COVID. Are there any signs of hope, and what kind of timeline would you guess at that we'll have a better handle on being able to fix this somehow?
Well, I think that there's now that you have this model at Mount Sinai, and they were able to come up, be the keynote speakers for in Indiana University. I know there's interest within RHI, the Rehab Institute of Rehab Hospital of Indiana, to set something like that up, to start having integrated clinics for post COVID-19. I think it's going to become
working. Are people who are going to that clinic?
At Mount Sinai, they've been having good results. Okay. They've been able to make gradual improvement with people, but they don't have a lot of data out yet. They've been kind of showing us some behind the scenes stuff that hasn't been published, but I'm sure that we're going to be able to make progress with these people. It may just be a much longer, it may just be a much longer progression to get back to normal. I will say that it's not going to have it's not going to happen as quickly as vaccine development did, because in essentially that was, the whole world pooling their resources to do one thing that was life or death. I think this is going to be something that we're probably going to have to fight a little bit for to get good funding for the research. I think initially we'll be able to get it, but over time, especially hopefully if the vaccination campaign works, that it'll be a thing that's going to be kind of like traumatic brain injury. You really have to fight to get the care that you need, but it's out there.
We're talking about the stuff that's in the 1 year period post-COVID, right? Like this disease is basically a year old, and the earliest people got it a year ago. I'm just hoping that there's nothing like polio, where you get like post-polio syndrome years and years later, given how long-lasting the effects are in the short to medium term.
Yeah,
It's too early to speculate about that, but
really, it is. There have been, all sorts of weird neurological things. There was that girl in South Carolina that got transverse myelitis. But that's crazy. The spectrum of strange, the spectrum of what I'd say organ systems that COVID-19 can affect is just it's pretty mind blowing. Everybody knows about its effects on creating blood clots, life threatening pulmonary emboli and blood clots in the lungs, and then how now it can affect the nervous system, the spinal cord. So yeah, we really don't know. But I would say that, if you go see your pulmonologist and your cardiologist and neurologist, and they're saying that we can't find anything wrong with you, then I would actively, even if you're not sure, if you had COVID and you're experiencing these symptoms, you're not sure they're related, I would definitely look up post-COVID-19 syndrome and see if there are any people in your area that specialize in it. And if not, it may be worth going to one of these centers, trying to set up an appointment there, because it's very under-recognized and it's hard to identify.
I suspect that today's conversation is going to be unsatisfying for a lot of people, including probably you and I, in the sense that a lot of the answers are going to be, we don't know yet, or we are just getting that information. So why don't we do a hard pivot to vaccines? As you mentioned, the whole world focused on vaccines. There's a whole bunch of them out there now. Most of the ones in North America are the mRNA vaccines. There are other vaccines as well. And I get questions about this all the time. I shared some of the questions that I was getting with you before we did this podcast. Why don't we try and pick them off and give people either some guidance or just, an honest assessment of what we know and what we don't know. So I think I was trying to think about reasons to get vaccinated to start with. And I think obviously stopping yourself from getting the illness is number one. And then if you do get the illness, it's going to be less, it's going to be more mild. It's going to be less severe. That's number two. Number three is not to give it to other people. And number four is to cut down on the vast number of infections worldwide so that we don't get as many variants developing all over the bloody place. Are there any other major reasons that we've missed, that I've missed there in my...
Nope, I don't think so. I mean, I think that if you're one of those people that's been talking about herd immunity since the beginning of this thing, you should be totally on board with this, because this is how in the modern era we achieve herd immunity.
Well, they thought they had herd immunity in Manaus in Brazil. There were studies coming out. I forget what the number was. They thought like 60% of the people living in Manaus had COVID, and therefore we were good. And then next thing you know, like a couple of weeks ago, they're airlifting babies out because there's no oxygen left in the city, because there's so many people on ventilators, there's so many people on oxygen, and there's a black market now in oxygen as people are
I guess the whole theory behind all that was that if this virus is really as transmissible as we say it is, then we're only capturing, with the people that are testing positive, a tiny fraction of all the people that are getting it. And so if that's true, then that means that all these people are getting it but not having any symptoms whatsoever. So therefore we should have a really high percentage of the population that's been affected and are immune and can't pass it on. It's like, that's so frustrating, because as many of the the models that people were criticizing at the beginning for trying to be too predictive and not having hard evidence, there's really no evidence that this was true. It was based upon a theory, which isn't, the theory itself isn't totally unfounded. You're probably right. If you're catching this many people through testing, there's definitely a higher percentage of people that you're not testing. But it looks pretty clear that it wasn't this overwhelming number that people thought it was, at the beginning. And so we're kind of learning that you can't just wish this away, and really we're not close to achieving herd immunity naturally anywhere. It hasn't happened. I mean, it's Sweden too. Sweden was no more protected than any other European country from the second wave and got absolutely hammered.
And got economically hammered as well.
And the state immunologist had to finally take a step back, who is Anders Tegnell, who said he never pushed herd immunity, but he clearly was. And now they had to start implementing certain social restrictions, which is appropriate, and but anyway, the whole point of this is that in the modern era, the way that we achieve herd immunity is through mass vaccination. Okay. We don't let diseases run rampant through our population and just kill off vulnerable and overwhelm our hospital systems. It's not. I mean, obviously, now we see that it was never really a feasible strategy. So if getting as many people vaccinated as soon as possible will generate herd immunity in a highly effective way.
Okay. So probably the number one question I'm getting is, hey, Stephan, I'm a doctor or nurse or some kind of medical health practitioner, or there's a reason why I've gotten the vaccine. I've got my 2 doses now. Can I go back to training normally?
So what I would say is so if I live by myself, I didn't live with my wife, I live by myself. And like one of my colleagues, we both have gotten both doses of the vaccine, and we talked about finally getting together and playing some guitar. But it's the chances of him carrying it and spreading it to me, and then me having it long enough to spread to my wife are really minuscule. But at the same time, it's it's not worth it for me. You know what I mean? But what I would say is this: if you live alone and you train, and you can train with some other, 1 or 2 other people that have also been vaccinated, then yeah, I don't personally have a problem with vaccinated people training with other vaccinated people. But we do not know. So the one thing that I think people misinterpret is just because you've had the vaccine doesn't mean the virus can't infect you. What it means is that the virus will have a much shorter period of time in your body before your immune system recognizes it and basically blocks it out and prevents any more cells from being affected. But there's a gap time, even when your immune system has been sensitized through vaccination, right? Like one or let's say 100 viral particles, which is 1/100th the size of a single cell, spread out in your respiratory tract, they're going to infect some cells initially, right? And so the question is, when they infect cells and they produce more virus, how much of that can you transmit effectively within the first few days? And the answer is we don't know. The truth is that it's probably significantly less, and it's probably not going to be, because I just want to be honest, it's probably not going to be as big of a deal as we think, we're worried that it might be. But in reality, we don't know yet. Yeah. So I do not feel comfortable potentially exposing my wife or anybody else in my family who hasn't already been vaccinated, by going out and living life normally. And also, I think it's, I'm just lucky being, 37, who just happens to work in healthcare and get a vaccine. I'm not going to walk around and flaunt, non-masking. It's not right.
You're not carrying a big sandwich board saying, by the way, I have been vaccinated.
So I don't have to wear a mask. Yeah. No, I think it's irresponsible. I think that if you're lucky enough to have been vaccinated, you're just lucky. There's nothing, I'm not as special, and I think it's important for us to be under the same restrictions that everybody else is.
Now, I'm not a public health professional, but when I have heard them talk, it seems like the number one question that they have is, can you have been vaccinated and thus be reasonably immune to getting really sick yourself, but still be infectious, which is exactly what you're talking about. And I imagine that there are thousands of people working on this issue right now that will have that answer fairly soon, whether they've had to go out, do trials, or whether they've had to do data crunching of the epidemiological data or the contact tracing. I imagine that we'll know that in a few months.
There's some unpublished data that shows, again, it's unpublished, which means it hasn't been peer reviewed, which for me, it's almost like I don't even want to talk about it because until it's been peer reviewed, we've talked about this before. I had a paper that I submitted and it got rejected 6 times. And then before I got accepted, I had to do 3 revisions. You know what I mean? So your first draft of anything is meaningless.
Yeah, it could be totally wrong. They could point out.
It could be totally wrong, right? And it's.
Are there tantalizing hints?
But it looks like, at least from these preliminary studies, that your transmissibility is significantly lower.
Okay.
I can't remember off the top of my head if there were, confirmed episodes of that, but I do believe that your transmissibility is significantly lower, at least in terms of like how much virus you're able to put out after exposure, from your respiratory tract after vaccination. But we don't know. But I think that we'll have an answer for that. I think we'll have an answer for that sooner rather than later, within a month or two. We'll have something out that'll be able to tell us that.
And I think it's important to point out that this is almost certainly a dose-dependent disease. I mean, I remember when in the 80s, when the AIDS epidemic broke, this idea was like, oh my God, you'd get one virus particle and it would take over your whole body. And I suppose that could happen, but the odds against that happening are 1 billion to 1, that you really do need an initial dose of however many particles.
Yeah, this is where the whole thing where it's actually your risk of exposure is significantly different. If you're a man having sex with a vaginal intercourse with a woman who has it, maybe not in the acute retroviral period, right when you get it, but after, a few months or whatever, your chance of getting it is really small. But if you're a man receiving anal sex from a man that has it, your chance is very high. So yeah,
that has to do with the dose and the route.
And it has to do with the vascularity of the rectum versus the vagina. And that's how I think the gay community gets so stigmatized, because this is a gay disease. No, it's just that because of the way that they have sex, they're just at a higher risk. You're not any more responsible having sex with a woman. You know what I'm saying? You're just lucky, and it's that whole kind of thing,
Yeah.
Yeah. So COVID's like that too, right? That's why there's time periods, right, where you can they'll say, okay, less than 6 feet with masks for more than 15 minutes, right? That's you're going to have enough exposure that period of time that your risk goes up,
Right. So the numbers that we do know, let me just run them past you and see if they correspond, if they're correct, is that for the Moderna and the mRNA vaccines that are floating around North America right now, you basically have a 95% reduction in getting COVID. And if you do get COVID, the odds of it being serious and bad COVID are much, much, much less. Is that still correct?
Okay. So, yeah, it was like, this was from the study that I read. And I think this was published in the New England Journal, I think, because I read the whole study when it came out, because I wanted to make sure I understood it. And it was like, in the group, there were 170 confirmed cases of COVID-19. So there was like, I can't remember how big the group was in the phase 3 trial. It was huge. It was like 36,000 people. It was a massive group, right? And there were 170 confirmed cases of COVID-19 over the study period. I can't remember if it was 3 or 6 months. Maybe it was 3. I'm not sure. And so of those cases, 8 were in the vaccine group and 162 were in the placebo group. 9 of the 10 severe cases were in the placebo group. So out of, let's say, 18,000 people around that in the placebo group, only one person only 8 people got COVID and 1 had a severe case. No one died. Compared to 162 in the placebo group and 9 severe cases, right? So, I mean, there really is just no comparison. And people need to keep in mind too that this is the phase 3 trial. So they've already had to go through non-primate and primate studies to make sure that the vaccine wasn't toxic before they even administered it to humans. And then they went through a small phase 1 trial where they ensured that it wasn't toxic and there were no severe adverse reactions. And that you weren't having a situation where the virus was reverting to somehow you're having like enhanced virulence of the virus should you get it. So, and then they did a phase 2 trial, which had a couple of thousand people to make sure that it was safe and that you were actually generating effective antibodies and neutralizing and binding antibodies before they even got to a phase 3, where that whole purpose of the phase 3 is to look at efficacy. So it was an overwhelming success in the phase 3 trials, but even now they're still checking. So in Israel is a really unique case. Israel was able to get a significant amount of vaccine doses. And I think that there was an agreement between Israel and either Moderna and Pfizer, whichever company is giving it to them, that they would essentially immediately report back everything, right? They were effectively doing surveillance work for
a stage 4 trial.
Yeah, exactly. Like, so, post, I can't remember what it's called in pharmaceuticals, or after you release it. But, and it's been an overwhelming success. I mean, the number, I can't remember off the top of my head, but the number of people that have been vaccinated and have gotten it is just, it's nothing,
Okay. So now what about long-term safety of mRNA vaccines? Because the naysayers, the anti-vaxxers, the conspiracy types, they're like, well, is it unknown effects of an unknown vaccine? To me, it's a non-issue because there are very, very few side effects in the short to medium term, but we know already that COVID has got very serious effects in the short, medium, and quite possibly long term. So the trade-off there is totally clear. But is there anything else that you would say to the people who are concerned about there not being long-term trials, or that
so they're really
was too rushed?
Again, for any drug, right? Like, you go through phase 3 trial, however long that period needs to be, and then the drug, if it's approved, is released. You're always following the drug after that for a period of time, and that's how, drugs that were safe on 100,000 people when they were studied, it's only after you test them on 10 million people or 50 million people that you find 10 or 12 really bad reactions that probably wouldn't dissuade me from necessarily prescribing it, but you have to report that. And then that might give some people pause. But this is normal, right? You have a phase 3 trial, you release the medication, we continue to follow it. But what I would say in terms of mRNA viruses is
mRNA vaccines.
Sorry, yeah, mRNA vaccines. And so, Stephan, correct me if I'm wrong on this before I go on, but the mRNA vaccines right now are really just to the spike protein, right?
Yeah.
So, okay, so then we'll start back after this. So the way that the mRNA vaccines work is basically you have a sequence of the viral genome that codes for the protein that actually binds to your cells. So in and of itself, that mRNA sequence is not enough to do anything. It's not the whole virus. And mRNA by itself, without the viral proteins around it protecting it, is unstable. It's not going to, it can't revert into a new virus. It can't itself really cause any viral effects. What happens is your body takes that mRNA sequence in, it reproduces it, it creates this one protein that is made by the virus, and then your body sees that one protein and then creates immune response to that. So you're basically taking all the parts of the virus out except for the one piece that binds to your cells and introducing its precursor into your body for your body to itself make it and then mount an immune response against it. Yeah. So it's really a pretty genius way of exposing your body to the thing that it most needs to create an antibody against in the safest way possible. It's really, it's genius. And it's actually, I think this is the first time it's been used for a large scale vaccination.
Yeah, I believe you're right. I think we're really lucky. If this had come along 10 years ago, we'd still be trying to make the vaccines in the conventional way by,
so inactive vaccines. So the interesting thing about this is, to me, at least logically, you would think that it would be at least as effective, but probably more effective than naturally getting the virus and mounting immune response against it. Because when you mount an immune response against a virus or bacteria, your body is creating antibodies to everything, all parts of the virus that it can bind to and recognize as foreign. It's creating all these antibodies. But the problem is that unless it's creating an antibody to the portion of the virus that the virus needs to attach and infect your cells, it's probably not going to be as effective, right? Now we can get into the different parts of the immune system and how even if you don't have a neutralizing antibody, you have a binding antibody, you still get a T cell response, all this kind of stuff. But the main idea is that your body probably spends a significant amount of time and energy making useless antibodies while it's also making the antibodies that will work.
Yeah.
Whereas in this case, you're really only making antibodies that are going to be effective in stopping the virus. And of course, you have the benefit of not actually getting the virus. So I would say that it's really tough science to kind of understand why. But for me, it's, hopefully I didn't explain it well, but for me, I have a lot of confidence that it is going to be highly effective and infinitely safer than actually getting the virus.
Yeah. I saw that one thing the anti-vaxxers were circulating was an account from Norway, which I believe Norway at the time that this was published had vaccinated something like 30,000 people, presumably mostly 80 years old and older, right? In that older age cohort. And the news headline, good old New York Post, was 30 people die after getting the coronavirus vaccine. So when you read actually further into it, I think 13 people die. Old people over 80 die all the time. So the vaccination was implicated in something like 13 cases. And when you take 13 and you divide it by 30,000, you end up like all medications have got some risk and some side effects. But I'll take a 13 in 30,000 chance of dying compared to, I don't know, what's the case fatality rate for over 80 crowd? Like 10%?
Probably, yeah. I would say if it was 13 and 30,000 in the entire population, I would say that would be not great. You know what I mean? But if you're talking about just in over 80, a cohort of over 80, then yeah, I mean, that would be
3,000
a factor of 100 difference, right?
Yeah.
You know what I mean?
Depending
but
on...
I'd be really interested to look at that study myself, because that to me, I haven't seen that, but that to me is, do you know which vaccine it was?
I'm not sure.
That to me is an outlier,
yeah.
You know? The other problem too is that, and it doesn't seem like this has significant impact on protecting you, but if your immune system is weaker as you get really old and you have a bunch of comorbidities, your ability to produce a robust immune response to anything, to the virus itself or to the vaccine, is limited. So we do know that people that are older tend to have less robust immune responses, less robust antibody response. They do produce antibodies, but it's not like you or I might produce. And also, they also tend to have, they don't have as bad as side effects. Like when I had my second dose, my first dose, I had no reaction at all, nothing. I didn't notice anything. The second dose,
you had a fever.
I'd say after about,
You had a bit of a fever, bit of a temperature.
Yeah. So the second dose, after about like 6 hours, because I was providing updates, after like the second or third update, I just felt kind of just malaise, just kind of crappy. And I had a little bit of a headache, but it's my typical, like, if I'm working like this all day long, my typical suboccipital, cervicogenic headache. So I'm like, okay. But the interesting thing was I couldn't make it any better. And I started to get frustrated. After about 12 hours, I was in bed and I woke up and I felt like shit. But that lasted like literally like 3 hours. And then I took my temperature, it was like 99.9 or something, which isn't a fever, but it's a little bit elevated. And I took some Tylenol. The next day I felt totally normal.
Right. So that's your body
the
actually
older crowd.
The
older crowd tends to not have that as bad. But yeah, I'm generating, right? My body's producing these viral proteins and my immune system's going like, whoa, what is all this? And, generating a really robust immune response. So that was, predictable.
Okay. So let's talk about one of the most worrying things, which is all these variants floating around, right? We've got right now, there's many variants, but the big ones that everyone's talking about are the UK variant, the South American variant, and then the South African variant. And the vaccines appear to be less effective on it, although still somewhat effective, and they seem to be more transmissible. And I think very soon now we're going to be in a situation where we're kind of in an arms race where we're busy vaccinating for a variant, and then there's actually selective pressure on the virus to evolve a new variant that's more resistant to the vaccine.
I think, honestly, makes even more of a case for vaccination because, like I said before, when you are exposed to a virus and you're mounting your own immune response, it's like if you try to invent a new tool, or you're an inventor, you try to invent something, you're going to go through 1,000 iterations before you find the one that works. And your immune system is running into these components of the virus and generating immune response against it, producing antibodies, and a significant amount of that time is probably wasted. You know what I mean? Eventually, you're going to find the right one. It's going to work, and you're going to knock it out. And that's the race that people have when they get sick, and their immune system starts to work. And if they don't make that in time, they decline really rapidly. That's part of it. But what I would say is that because you're probably, and this is just theoretical, if you're probably not generating as many different specific antibodies to the spike protein itself, which is the most important part, your ability to withstand, to not have a bad or a new infection with one of these variants is probably lower, because that is the thing that infects you, and that is the very thing that is mutated on these new variants. And that's the most dangerous part, right? Because, theoretically, if you generate an antibody to the spike protein, the receptor binding site that actually binds in your cell, and you only maybe have one form of it, and now that part is a little bit different, you're going to get re-exposed, and it's as if theoretically you never had the virus. Whereas with the vaccine group, it's probably true that you're going to have more protection, right? Because you've generated so many different types of antibodies against this spike protein. And it looks like it's starting to be borne out that, yeah, the vaccines are somewhat less effective, but they work. Now, the significance of the decreased efficacy, we don't know. But again, like we were talking earlier, the typical flu vaccine is, I don't know, sometimes 70% effective, even 50% effective will, keep cases down and protect a lot of people from bad outcomes. So I think we're still in a good spot with vaccines, but it definitely raises the alarm that this is what happens when a virus just reproduces unchecked.
Yes.
Right? If a virus reproduces over and over and over and over again, it doesn't have the same mechanisms like our cells do to prevent mutations. Our cells have so many layers of defense to preventing mutations because that's how cancer develops, right? Viruses are very crude machines, and they develop mutations all the time. Most of the mutations result in nothing. Right. They don't affect us. Sometimes they can make the virus weaker, but if you have a virus that's circulating over and over and over again, you're going to run into a few of these mutations just out of chance that make it more dangerous. And that's how it's been, pops up randomly. It pops up in South Africa, pops up in UK, pops up in Brazil. It's just random that these happen. But now we've got these three variants that are out competing the current strains.
And it doesn't. Which means I go back to like evolutionary biology classes in university. And it's an exponential growth situation. If you have a tiny, tiny advantage over the course of a few generations, you end up becoming the dominant thing. So, for example, I don't know, let's pretend that eyebrows. My tribe is, my offspring are competing with your offspring, and you don't have any eyebrows, and I do have these great big caterpillar of eyebrows. And they give me a tiny, tiny advantage, a 1% survival advantage, because I don't know. I'm making this up. Raindrops don't fall in my eyes. Or, dust doesn't get in my eyes when I'm about to spear the woolly mammoth. That tiny survival advantage that my offspring are 1% more likely to survive than your offspring, in the course of 10, 20 generations, basically everyone's going to have eyebrows. That gene propagates so quickly. And we're talking about a virus.
Unless you have a tribe of people that is totally isolated from the people with eyebrows. And so, like somebody that lives on an island.
Sure.
And so they're never having to compete with this other group. But in general, 100% that's true.
And so even if we've got so many different experiments running, by which I mean infected people, I mean, how many people are likely infected right now on the planet? I'm going to 100 million.
Yeah, probably something
Probably
like
a right
that.
number. And then how many virus particles are reproducing inside the average person with an infection? In the
The
range.
stars in the universe.
Yeah, we're talking trillions of little experiments where, because it's an RNA virus, it's more variable than a DNA virus. It's much more variable, as you pointed out, than human cells, because there aren't all these mechanisms to prevent mutations. The mutations are just going to accumulate, and the less under control this is across the planet, the more these variants are going to come up inevitably.
And again, most of these mutations are going to result in nothing, and they're not going to be important. But every now and then you are going to have one that is going to be more dangerous. And the thing is that there was some really good analysis talking about why having a more transmissible strain is worse than having a strain that's just more
deadly,
lethal. And that's because if you have a strain that's 50% more transmissible, just the number of additional people that you will infect, and the predictable number of deaths you'll have as a result of that is going to way outpace the number of deaths you would have just from a more lethal variant that's not more transmissible. So
Ebola is unquestionably more deadly than COVID, but it didn't spread very far.
Yeah, exactly. So transmissibility in this kind of situation is everything. Another interesting thing is that I was reading, it was from South Africa, but I was reading another article where almost in these people that can't clear the virus, they're reservoirs for these mutations, right? They're reservoirs for these mutations. So if you're in an ICU and you've been there for 4 to 6 weeks and you're still producing virus, you haven't created an effective immune response, you're that little experiment inside your body. You're the virus is reproducing. So it's not just going from person to person to person. It also matters like how long all these people are affected. You know what I mean?
So let's try dragging this back to jiu-jitsu and other, we'll use jiu-jitsu as a proxy for getting back to life. If we can get back to jiu-jitsu normally, then we can start going to movies. If we can, we can start going back to restaurants. So the first thing I want to say is that the people who are still listening and are super crazy mad at you and me for wanting to destroy jiu-jitsu, I'd like to point them to grapplers.com/openingupbjj, in which we very explicitly, I published and you came up with guidelines for actually training jiu-jitsu. This dichotomy of like, we're open or we're closed. You don't do anything, or you do everything and take every risk, is a false dichotomy. It's not a choice like that. There's a range of options in between. But let's drag this back to jiu-jitsu. So my first question is with regards to variants. If I've gotten vaccinated and I start training with somebody, what are the chances that a variant's going to come along that shuts everything down again? Here's the Papua New Guinean variation. And the Papua New Guinean variation, the vaccine's only 20% effective, and now everyone's got to get revaccinated again. And now we got all these variants floating around. Now, can you only train with people who are vaccinated, whose entire vaccination schedule is up to date? How does that work?
So,
or is it too soon to say?
Well, that like encountering a variant that would render the vaccine like 20% effective would be something that would throw like a monkey wrench in the whole situation, because we don't really know what 20% efficacy means. If you say, 70% efficacy, 60, 70% efficacy, like in my opinion, if we were able to get the whole world vaccinated in the next 2 weeks, and then because you achieve like 91 to 95% protection after like 7 days after your second dose, I think. I'd probably wait 14 days before I went back to normal. But if you got all that done, I would say that with the way things are now, I would theoretically, again, like everybody's vaccinated, I would say I'd be comfortable kind of going back to normal. I would. Okay. But if all of a sudden, we find out there's a variant that's the vaccine is only 20% effective, it's almost like starting over again, right? It all depends on like, were they able to contact trace, shut everything down, get everybody tested, it's like, I'm saying, it's almost like starting back over. And if not, then I don't think it would be that big of a leap to be able to modify the vaccine and get it out.
Yeah.
Now, we'd be much better at it the second time in terms of distributing it and everything, but it depends. Like, I think if that's really hard to say, but let's just say that we're stuck with the way things are now with the variants we have now. I'd say if we get everybody vaccinated again, I'd be fine. Like everybody go back to normal. Right now, I would say that if you're vaccinated, I can't guarantee that you can protect anybody else that you live with that's not vaccinated. I can't do it. And so I'm not any more comfortable saying that like you can just go out and interact with a bunch of people that aren't vaccinated and come home and feel good that you're protecting everybody else in your house. You're not, and you don't have any reason to believe that you are right now.
That might change. We might.
Yeah, that might change again. We don't know, and I have a suspicion that it probably is safer than we think, but I can't say that yet. But I would say like if you live at home and you and your wife are healthcare providers, and then you got the vaccine, and then you live with your two elderly parents and they both got vaccinated, then yeah, I think that you're protected at home. I do. I believe in the vaccination. I really do, and I think that you're protected. What I would recommend is that if you're vaccinated and you live with people that aren't, I would say if you're going to go back to jiu-jitsu, either continue with the restrictions that are available at your academy, or find a cohort of people that are vaccinated. And it shouldn't be hard in like a city to find a couple healthcare workers, you know what I mean, that really want to train, and you've all been vaccinated.
And you could even approach a club and say, hey, we're looking at your schedule. Your 10 a.m. to 11:30 a.m. slot is open. This
is like what we talked about with the people that had just had COVID, right? If you have a bunch of people that had COVID and had cleared it, they had confirmed COVID by testing, went through a course, so you knew that they got sick, they cleared it, they're asymptomatic, and you got a group of people like that. That's a cohort that can train normally together.
Yeah.
So yeah, I think this is like the same thing.
Okay. Any insights? There's a whole bunch of people now who've had one dose, but not two doses of the 2-dose vaccines. I know that there are 1-dose vaccines. I think it's the Johnson & Johnson vaccine, but that's not widely distributed yet. So let's just talk about the 2-dose vaccines. If you get one dose, can you train right away? No.
I mean, well, the thing is that I can't remember what the efficacy is after one dose, but the problem with it is none of these studies, like the clinical trials, the phase 3 trial that I read, was designed to assess the efficacy of that. There wasn't like a dedicated analysis of like, okay, we're going to vaccinate this group with one dose and just let them go. It wasn't like that. You either got 2 doses, you didn't get any. So you probably have some degree of protection, but it's like the best analogy that I read about 1 to 2 doses is like you taking a class and like sitting through a lecture one time, and then versus like taking the class, sitting through the lecture, and then going home and then studying it and making notes and stuff, right? Like your immunological memory is significantly increased, and just the amount of memory B cells the B cells that produce antibodies and T cells that are designed specifically against this virus dramatically goes up after a booster, right? Because your body's already kind of, after the first shot, it's totally naive. Your body doesn't know what it is. It takes a little while to generate an immune response. It starts to do it. But then once you have that second boost, your immune system's, once it's already seen something, you have special cells that remember it, and they circulate in your body for a long time. We don't know exactly how long for COVID, but much longer than just a month or two, for several months, probably years. And once that virus is re-exposed, boom, you have this massive immune response and you are highly protected. So I would say no. I mean, and if you got the first shot, you probably had to sign up for the second one. So you've already waited 10 months or whatever to train. Just wait another 2 or 3 weeks.
But there's the rub, because I know in now that vaccine shortages are happening and that vaccine nationalism is happening and like, no, we're not going to send you the vaccines we promised you. I know in Canada, for example, that 2-week or 3-week time span has now been spread out, I think, to 40 days. Like it's there's a lot of people the time between first and second dose is a lot more than was advertised in a lot of places. And it sucks. But, you know, what part of this pandemic is good? Not very many parts.
Yeah. And honestly, like, you know, then the point of allowing you to get, there's really probably no, I mean, whether it's 2 weeks or probably even up to 2 months, that booster is going to be effective. It's going to have that same effect. Now, I don't know if you wait 6 months, it honestly probably still will, but I don't know. I mean, the idea is that you want to do it. It's kind of a game, right? Because you want to make sure that you've mounted the best immune response you can after the first one, right? It doesn't make any sense to just give you an extra massive dose before you've finished your immune response. But at the same time, you don't want all those cells that you generated from the first immune response to fall out of circulation, because then the booster won't be as effective. But I think whether it's 2 weeks or 40 days or 60 days, it's not really going to make a difference. I think the booster shot's still going to do its job and be effective. I would say maybe the reason that I think that the whole rollout, I can't comment on. I think it's been a disaster for a bunch of reasons. I can't even comment on that, but I have ways that I would have done it, but you know, I'm not a public health expert. But what I would say is, if you were allowed to get that first dose without being guaranteed to get the second one, that wasn't so that you could just go integrate back into life. That was to try to just in some small way to protect you from severe outcomes, overflowing, overburdening the hospitals and trying to protect people that you live with. It wasn't to give you full immunity. So people need to understand that difference.
It's a tourniquet to maybe stop you from dying.
Yes.
Now, when I launch this podcast, this episode, I'm already anticipating just a gigantic backlash as the COVID deniers and the hydroxychloroquine pushers and the 5G, 5G fans and the horn-wearing shamans pivot to anti-vax. And I'm expecting a really vicious anti-vax attack. Have you had any luck talking to anti-vax people about the vaccine and actually changing any minds? Or have you changed?
Not pure anti-vaxxers, but I have patients, they'll be like, did you get that vaccine? And I'm like, yeah. And they're like, I don't know. And I'm like, and that actually stops our clinic visit. And we have a discussion about that, regardless of why they came in. We'll talk about that. And I would administer myself 2 doses to every person in the world that I care about, without batting an eye at it. I did it myself. That's all I can really say is that, if I'm wrong about this, I'm willing to go down with the ship. You know what I mean? And there's just, with people that are pure anti-vax, I don't know. It's a conspiracy, and it's can't talk to those people. But I feel like I've made some progress, especially with people that were not necessarily physicians, but other people that work in healthcare that are kind of like, well, I was going to wait until a bunch of people got it to see how, and I'm able to make progress with those people.
What did you
patients
say to make
that are
progress?
kind of on, meaning getting them to be like, okay, all right, well, I was just worried, but the way you say it makes sense, and okay, yeah, I'll try to get signed up. I don't know if they're just saying that because they don't want the visit to be awkward or whatever, but I feel like we've gotten somewhere.
Not only am I not going to fix what hurts in your body, I'm a jiu-jitsu black belt, and I'm going to make your body hurt a whole lot more. No, I'll get the vaccine. Vaccination through intimidation. But what did you specifically say to those people, other than endorsing it with your credibility?
So normally what I just asked them, I was like, well, what is your concern? I ask them what they're worried about. I ask them what they understand about vaccines. And then what I really do is I try to explain to them that basically the difference between getting the virus and getting the vaccine, like what it is, right? People are afraid of the stuff in the vaccine. You're talking about taking, what, 0.3 milliliters, or like not even a full milliliter, I don't think, of material and putting it in a muscle. You're not injecting it into your circulation. It's not gonna, it's not, you're not injecting it into your spinal cord, and it's basically, it wouldn't work unless your immune system grabbed it and pulled it into your body to figure out what it is. And then I explained to them that it's basically like you take a virus, you deconstruct it, you only take out the part that you need to kill it, but at the same time, you're not exposed to any of the risks associated with actually being infected with the virus. It's like has all of the benefits and like none of the downsides. You know what I mean? And that's kind of, I try to explain like that. I try to meet people where they are. If they don't know what a virus is, I'll briefly explain it. But basically, I just try to make that point that you're achieving the same goal as you would if you got the virus, except that you're not having to go through having the virus.
Okay.
It's
so what then is your, see, I'm not seeing that much of resistance at that level. What I'm seeing more of is people going, dude, this is too rushed. It's less than a year to a virus to a vaccine development. It's all the fastest we've done it before is 4 years. Maybe I'll take it, maybe I won't, but I don't want to be the first guy to take it.
So basically I had one conversation like that. I don't know how much headway I made. It was via Facebook Messenger. This guy reached out to me and talking about that, and just saying that it was too rushed, and I'm like, but my argument against that is it went through the exact same processes as everything else. The difference is that in this specific instance, the entire scientific industry was focused on one thing. And so it was sped up. It was just, you were able to recruit more people because more people wanted to help out with the situation. You were able to recruit, you were able to get more money, you were able to get more resources. It'd be like, it's how like everybody, you may have a poor family that lives down the street from you and their house is falling apart. Their heat doesn't work, and in Canada that could kill you, and they've been living like that for 5 years. But 2 weeks later, their house burns down and the whole community comes together and raises $100,000 for them, right? It's that effect. It's the effect of immediacy and severity and in your face. But I explained to them the whole the whole clinical trial process. And then I tell them that I read the phase 3 trials, and I explained to them what trials are, and that the time period isn't as significant as the population that was exposed and what was done.
And so I just mention that if you're the CDC regulator or the FDA or whoever, whatever regulatory steps you would ordinarily have to go through, if you and I were submitting, I don't know, a better Rogaine, it would end up at the bottom of the pile of studies to review.
Right. And how long would it take before it even got up to them to review it?
Exactly.
And then once they reviewed it, what's their incentive to try to sit down and write everything they have to write and get back to me and you? But this,
I guarantee that this arrived on somebody's desk at 7:00 on a Friday night, and they stayed at that desk until 10 a.m. on Sunday morning.
100%.
Yeah.
I mean, if I had looked through all the data and was like, man, this phase 3 trials is so small. It's just everything. It's just not like that. You know what I mean? It wasn't. I don't know if you want to use the word rushed, because rushed implies that it was done poorly or incompletely. It was hastened, I guess. It was by necessity, and that should be a good thing. Yeah. That science, look at what we're capable of when we pool all of our resources. Yeah. I think it's a good thing. I just think these conversations have to be had a lot of times like one-on-one. You know what I mean? Where somebody can, but da-da-da. And then you can say, okay, all right, I see your point. You know what I mean? But if it's just information from a third party coming at you and information from a third party coming at you here, you're going to migrate to your tendency to believe science or conspiracy. It's tough.
Okay. Is there any questions that I should have asked you or that you want to answer even without me having asked you?
So, and these things weren't asked of me when I got my vaccine, right? I don't think I was asked if I'd had COVID-19, but I wasn't asked anything beyond that. And on the form I filled out, there wasn't like, if yes, then did you have this or this? I think it's important for people to be aware of this. So if you've had COVID-19 and you received, a monoclonal antibody against the virus, or you receive convalescent plasma, you should probably, the CDC is recommending you wait 90 days before you get the vaccine, because you don't want anything that's passively pushing down the virus in your body, or not the virus, but that's passively could be working against the vaccine in your body. These proteins that you're producing, you want your body to see it, as much of it as possible, to develop a really robust immune response. So if you had, COVID-19 specific therapies like monoclonal antibodies or convalescent plasma, it's really important that if you happen to have had that in the past 3 months, that you probably talk to your doctor about it and see what he thinks. But I think the CDC is recommending 3 months before you get it.
Man, I had not heard that at all, and I thought I was fairly tuned into this. So thank you very much for that.
And then the other thing was, the CDC website. Stop. Sorry, my dog's starting to get a little restless. But the CDC website also talked about prophylaxis for like analgesic prophylaxis. So Tylenol or ibuprofen or something for when you get the vaccine. Now, I said if I probably would have done it for after the second one had I known. Now there's some concern that, we don't know what impact that's going to have on how robust your immune system response is. I think maybe anti-inflammatories like ibuprofen, or I don't know which ones you have up there, but your typical NSAIDs, ibuprofen, naproxen. I would say maybe don't use those prophylactically, because those do tampen down inflammation. But we use Tylenol all the time with people in the hospital, high dose Tylenol with people all the time in the hospital when they're acutely ill with something, to, allow people to relax, to sleep, to feel better. So I'm, right now there's no data on it. I think it's just theoretical, but for people that are getting that second dose, you might expect that you're not going to feel that great for the first 12 or 24 hours. And if you're starting to feel a little crappy, I wouldn't be worried about, I would go ahead and take 2 extra strength Tylenol every 6 hours. I mean, that's probably the first time I've ever gone against like science, but honestly, I don't think it's going to have an impact. And definitely take it if you start feeling like crap. Don't just not sleep at all.
Yeah. I think reframing that is also important. Like, that is your body doing the work it's supposed to do. I mean, it's like if you woke up in the middle of the night with a stabbing pain in your lungs, you would be rightly concerned. But if you've just finished wind sprints and there's a stabbing pain in your lungs, you're like, oh, that's a good burn. It's the same pain. It's a different context. So I'm sure that it was, with your knowledge, knowing that this is my body mounting an immune response. This is what is supposed to happen.
I was prepared for it, but it was more funny to me. It was more like,
oh, this is what it is.
Yeah, it's more funny. Like, I would still 1,000 times out of 1,000 get the COVID vaccine. I wouldn't even think about it. Of course I'd get it. But it was kind of funny because I've never had a reaction from the flu vaccine or anything. But so it was kind of funny to me. And I was like, wow. I remember I woke up to take the covers off of me. I was like, I'm going to go take a shower. And I was just like, oh my God, it's freezing. You know what I mean? And it just made me laugh because I was like, wow, okay. I'm having a little bit of a post-vaccine reaction. But like I said, I took 2 Tylenol. I was like, the next morning I woke up, felt totally great. Yeah. So, expect that. And, you may need to take some Tylenol. That's all.
Okay. Just to wrap up here, we'll point people once again to grapplearts.com/openingupbjj. I think we'll have to add some notes there about our vaccination and the implications of vaccination for training jiu-jitsu. And I think we got to have you back even for a short session in a month or two once we have a better idea of A, what the hell's going on with the variants, and B, whether there's now evidence about being vaccinated, what evidence there is for reduction in infectivity, how infectious you are after you've been vaccinated. Because that I think has a lot of implications for society and for the sport.
For sure. And I'll put some updates on the reopening guidelines that specifically address the vaccine. I think there was some verbiage in there before, but now I can be more specific.
Awesome. All right. Well, I hope you and your dog have a great rest of the day.
This is Ron.
Well, we appreciate his contribution. Take care, man.
Thanks, Ron. Take care.